I'm gonna have a fairly brief talk, and I would like everyone to chime in if there are any questions in the middle. It would be much more useful, I believe, for you if you just ask me clarifying questions, if there's anything you're interested about. So I'll start with a little bit introduction about myself and about Google Health and its focus areas, and then I'll go over to talk about the data science work that we do at Google Health, and in particular, two of the projects that I'd like to share with you. And I'll leave time at the end for any questions you might have for me about Google Health, Google in general, or data science work after about ICME or anything you can think of. All right, so a little bit about me. So just to clarify why I was cheering for a Polish team is because I actually grew up in Warsaw, and I spent most of my life before coming to the US in Poland. So this is why we were cheering for the Polish football team. Anyway, so I graduated in the summer of 2019, as Karen mentioned. I work with Professor Susan Holmes on statistical methods for high dimensional data analysis. We worked a lot on kind of analyzing biological data sets, in particular transcriptomic RNA-seq and microbiome data. And so my thesis was on robust dimensionality reduction methods for data visualization and the latent structures recovery. So after this, in the fall of 2019, I joined Google Health, and this is basically my first experience with industry and my first job. And currently, my main focus is working on quality evaluation and improvements to the clinical tools. So these are some of the features that I will talk about in the next part of the talk. So clinical tools are some software solutions that we develop on top of the electronic health records data that facilitate the process for the clinicians in the hospitals and also in the clinics. So let me talk about the Google Health focus areas. The main mission, a little bit cheesy one, is to help everyone live more life every day through products and services, mainly the software that bring the health information in a more efficient way to different people. And these people could be the first group we're targeting are the clinicians, so the doctors and nurses and all the care people that might help you with your health, with treatment, with management, etc. The second set of people are the individuals, so yourself, basically anyone that is interested in improving their health or managing. And then there's the third set of focus, which is basically circulating around the prevention and prediction. So these are more open-ended, either research, but with keeping in mind that we want to convert this research to actionable activities. So to help the doctors detect some of the diseases early on, or to predict some of the more administrative outcomes. So this is all revolving around the general whole of Google mission to organize all the world's information and make it accessible to everyone. So if you'd like to learn more about these projects, there's a simple link you can go to and check the different projects out. It's simply health.google. And so now more about all of these three pillars. So on the clinical tool side, when we develop solutions for doctors, these are mainly focused on three different features. So the first one is around the search tools, which basically works like Google search, but aimed for doctors, and the search is over the EHR data. The second one is Streams app, which is an alert system for the doctors to basically detect different outliers or a lot of adverse events early on. There's also ophthalmology, which basically is the project that is derived from the research on different types of diseases related to the eye. And we actually have solutions and basically the products now that are working as an assistant to the doctors in the clinics. They are not deployed in the US, but in other areas of the world where there's a large shortage of doctors. So you can also go on the health.google to learn more about these solution. I am in this talk mainly going to focus on clinical search tools, and we'll see what this is about in the next slide. The second umbrella encompasses the solutions for individuals. So, you know, there's a Google Health app. There's also other areas such as new health studies conducted by different scientists with Google's technology to assist. So you can sign up right now, actually, on the Google Health website to see what the studies we are currently conducting. Then there's also clinically validated self-assessments. So these are screeners for depression, anxiety, PTSD, or postpartum depression. And so these are also available on the website, and these are targeted to the individuals. And of course, on the research side, there are two main we call departments. So imaging and diagnostics. So most of the work is in computer vision. And then there's also genomics that uses both the open source data and trying to also integrate with imaging as well. And there are also an array of different other research projects that are in dermatology or other types of data, also on the EHR data. But the research, of course, is conducted on the open source data usually. So on the clinical tools side, basically, we are developing a Google search and kind of automated summary of the data to make it easier for the doctors to browse through the patient's medical history. So currently, if you go to the doctors, you will notice that nurses and physicians enter a ton of data into the computer. They take notes about your past medical history, your family history, etc. Everything is stored in the EHR. There are even legal requirements to document certain items, and these basically takes up a lot of doctors' time. I think even like half of the day can be spent on writing notes, exploring the EHR system, finding things out, and it's basically wasting doctors' time, and they spend less of that valuable time with the actual patient and on their care and treatment. So our incentives is basically try to declutter this mess of the EHR data, to streamline the workflow, and to basically pull the data from different EHR systems, because there are many of them, into a single place where the data can be represented as a real-time, normalized, and longitudinal sort of time series data. And then to automatically generate summaries of this data so that the most relevant and important pieces of information are basically visible to the doctor without having to click sometimes 30 to 60 times to figure out what's going on with a patient. So I mentioned 30 to 60 clicks, which sometimes this is how much it takes to find the medication to order for a patient. This is incredible how much work it takes. So yeah, so the solutions we want to provide revolves on data summary and visualization, making everything very intuitive, the same way as you would use the regular Google search. You basically can type in anything, and we want to basically support the language that is natural for the doctor. So any abbreviation that are frequent in the medical domain. Yeah. So let me actually show you how it looks like. Karen, could you take over and pass the video?
Okay, give me 1 second here.
Yeah, the product is now called the Care Studio, and you'll see through the video what are the tabs, what are the views of the data that the Care Studio provides.
Just 1 second, I'm trying to tee it up here. Okay. Shall I play the video now?
Could you also full screen?
Hi, I'm Dr. Pete Clardy. I'm a pulmonary and critical care physician and clinical specialist at Google Health. Today, I'm excited to introduce Care Studio. Using Google's expertise in organizing complex information, Care Studio provides a unified view of patient records, making them more accessible and useful for clinicians. In Care Studio, you can browse and search through patient information. Let me show you what it can do. The chart you're going to see uses synthetic data, meaning it's not real patient data. When you view a patient record in Care Studio, you've got all the information together in one place, even if it comes from different EHRs within your health system. Finding a patient is easy. And once inside the chart, the Encounter section shows key information about the current admission, including a useful summary that Care Studio extracts from the notes. The Overview tab shows a rundown of the whole chart. But let's take a deeper dive into each section. In Vitals and Labs, results from different EHRs are shown together, plotted on the same graph, because Care Studio harmonizes information from multiple sources. The same goes for medications, whether given as an inpatient or an outpatient, as well as reports and orders. Notes are the backbone of the patient's story, but it can be hard to follow that story when redundant information overloads medical notes. Care Studio understands what's new and makes it easier to find what's important. It also generates an outline of each note so you can jump to the section most important to you. But bringing everything together is just the start. Care Studio is also a search engine optimized for healthcare. Clinicians can simply type what they're looking for into the search bar to have it pull up medically relevant information instantly. You can enter almost anything into the search bar, from clinical shorthand to everyday language. A search for diabetes pulls up glucose, ketones, and hemoglobin A1C, as well as notes which reference clinically related concepts. Type any combination of labs and vitals to efficiently compare values, or search for information in a specific part of the chart. When building tools for clinicians, we know that healthcare data is sensitive and personal, and it's our responsibility to keep it private and secure. That's why Care Studio is designed to protect patient information. Our products adhere to industry best practices and regulations, including HIPAA, and we don't own, nor do we ever sell patient data. We're excited about the opportunity to support more proactive care for clinicians and their patients.
Okay, thank you. I will start sharing my screen again. All right, so I'm very happy to be able to show you the actual product because we basically just launched this to a limited set of testers from the partnered hospital. So around 250 doctors now have access to this product, and we are in the testing phase to see what they think about this search tool and how to improve. So actually before last week, I wouldn't be able to show you how this, okay. So any questions before I jump into the data science work that we do? Okay, so I'll move
Actually, I have
forward.
a question, Lan,
Yes.
if you don't mind, before you jump into that. You know, the interesting thing in thinking about doctors and friends I have that are doctors is often are reticent to use new technologies. And I'm wondering what you're doing as a team to build trust. Because I think that's a challenge with data science and AI tools is how do you build trust among people who are not data scientists? Or machine learning specialists? How do they accept that what you're doing will really help them and will complement their work and be useful? And so I just curious about how you all have addressed that.
Yeah, definitely. This is some of the work we do on the data science on the quality that I'll talk about to ensure that the quality is up to standards. But definitely the aspect of convincing or persuading the users to actually engage with the product is something we need to think about. So this is why we first rolling it to the small group of doctors and seeing their reaction. And then incorporating the basically the feedback. So the thing is that the EHR system is really outdated. I don't know if you've ever seen it, but it might look like 90s HTML. It's really hard and painful to work with. Plus, they have to engage with so many different EHRs. So imagine you are a doctor and the inpatient, so the hospital data when the patients are actually admitted is kept in one type of EHR, let's say Cerner. And then the outpatient data is kept in a different system, let's say Athena. And basically, the outpatient data is the data where the patient go to the clinic, so outside of the hospital where the doctor is treating the patient, but some previous encounters. So you need to log into multiple of these systems to find the data, and you cannot search with these shortcuts easily, like we've seen in the video. So basically, through experience and then testing the capability of this Care Studio, basically the users need to learn what the product does. And this is not replacing the EHR in any way. It's just a supplement because you still need the EHR system to right now write your notes and enter anything into the system. So this is definitely not replacing, but it's basically a supplement, which basically is helpful, let's say, during the initial patient's review, or also on the mobile apps, which I think this is a major plus because it's easier to navigate the Care Studio rather than the EHR on a phone. And the doctors are a lot of the times on the go. So it basically will make it easier for them. But building trust basically goes over time. We monitor basically the user activity and look at the comments. And also with super users, I guess this is how we call them. This is basically just word of mouth. So if certain users find it helpful, they will train or teach other users how to use the product. And basically, the adoption will increase. Okay, so I think I'll move on to the next part where we basically, with the data scientist, work in ensuring the quality and other aspects. So there, right now in our team at Google Health, we have different kind of blocks that we focus on. The first one, a lot of the product analysts work on data quality. So ensuring the input data, the raw data that we receive from the hospital is validated. So there's a lot of steps in harmonization, standardization, and checking whether there's certain chunks of data missing, if there's anything that looks irregular. This is one part of the quality assessment. There's also another part where we assess actually the quality of the features we develop. And that entails like evaluation, the design. So before we hand over the product to any doctors, there's a lot of cycles of iterative process of improving the feature. So we work with even a smaller set of testers to who aren't the doctors eventually using the product, but medical students, let's say, a lot of them actually are at Stanford. And they basically help us evaluate the accuracy and other aspects of the features we develop. Then basically the work involves metrics definition. So what is it that we actually care about? And then the analysis of the data that we gather. So this is on the clinical tools. Then once the product is used, there will be logs of basically what the doctors are doing with the feature. And analyzing this also helps us ensure the quality. And also data scientists sometimes are engaged in the predictions and modeling projects as well, where we basically try to predict certain outcomes for the patient. And this also involves some evaluation work for the models and also looking into the fairness and robustness of these models and designing the metrics as well. Okay, so the two projects that I will talk more about are basically this quality assessment on the clinical tools, and also some of the efforts that we did early on in the pandemic to forecast hospital admission for some of the partnered providers. Okay, so moving on to product feature quality evaluation. So why is it hard? As you mentioned, it is kind of not trivial to gain users' trust. At the start, when you're proposing a new set of features or a new data summary layout, this thing doesn't exist. It hasn't existed before. There's nothing like this in the EHR. So you need to figure out how helpful this new solution is. And what aspects are truly important. And so you can think about like accuracy of the information you surface, the comprehensiveness of this information, and whether the organization of this information is sufficient, and how fast can the doctor actually access this? Does it actually save up their time, or it's even more cumbersome to use? So different doctors will have different weights, or the aspects that I listed here might have different importance to individual clinicians, depending on their specialty or even individual personal preferences. So we need to figure out how to collect their opinions, how to collect the ratings and aggregate them in an informative way. And basically designing even the adequate instructions that clearly collect the insight that we are after is one of the most challenging parts of this evaluation process. Okay, so we are dealing with human raters, and these are tasks that require expert knowledge. So it's different than quality evaluation for the regular Google search, where you basically have queries and then a set of results ranked on a web browser. This requires some of the medical training and knowledge in order to figure out whether the feature is surfacing some information that is relevant, that is accurate and comprehensive. So this is why we work with medical students as well as physicians who like spend part of their like weekly time to basically answer a lot of surveys that we send to them that allow us to quantify how well we're doing. But this is a little bit hard sometimes, because if you ask two doctors, sometimes you get back 3 opinions. So a lot of the tasks are inherently subjective, and it's hard to figure out how to combine the insights gathered from different doctors. So example of tasks that we ask doctors to complete might be, let's say, providing them with an image of an eye and asking what is the risk of glaucoma on the image that we're displaying. So next, I'm going to talk about how to assess the radar's reliability in the absence of the ground truth. A lot of the times we're working with the data that doesn't really have the ground truth attached to the data points. And then in the next part, I will talk about how to smooth the ratings collected from the inherently subjective questions that we ask. Okay, so here is basically the objective. If you are gathering the data from the human evaluators, and they all have different opinions, you really don't actually know the ground truth, and you want to actually be able to estimate it. The difficulty here is that we cannot ask thousands of doctors the same question because it becomes very expensive. What we work with usually is 3-5 doctors complete a single task. So in some cases, there is a process of adjudication where we ask the group of doctors to sit down and resolve their conflicting answers, and then come up with a consensus for basically, let's say, a label for an image. But this process is very expensive and it takes a lot of time. And as we have a lot of updates to the algorithms we develop, having always the ground truth is infeasible. So the type of evaluation data that we actually work with is this, let's say, either a fully crossed data set where every rater answers every question. So in this case, we call it fully crossed. In a small subsets of these data, we will actually ask the raters to adjudicate, so the process I just referred to, and then we would have a proxy of the ground truth called the golden data set. And this golden data sets usually can help you figure out how accurate each of the rater might be. But in real life, the raters are labeling only a small set of these adjudicated samples, and you might not be able to find a fully crossed golden data set in order to estimate this reliability scores. So this is why we might have to work with something we call a silver data set, where you have partial overlaps. So each task is labeled by a different small subset of the raters, and each rater labels a similar number of tasks. So this design is basically feasible in practice because you assign the task to different raters in the same way. And it's less expensive than to have every example rated by every rater. So yeah, I already mentioned this. There's a varying number of raters labeling every single task, and there's a varying number of tasks labeled by each rater. This is in general what we observe in the surveys that we have. So how do you use this not fully crossed data to estimate the ground truth? So you can basically take this approach of David's skin model, which is based on the original paper from the 70s, and which is basically an EM algorithm that gives you the estimate of each of the raters' reliability and also gives you the estimate of the ground truth. So the setting in this paper is as follows. So basically, clinicians would correspond to the raters you have, and clinicians go on to visit different patients. And every single time, the patient might have a different recollection and a different opinions about what it might be happening to them. So the clinicians observe some sort of noisy data, and these are corresponding to the task that we have in our survey. And the paper goes on to basically describe how you use this kind of data to estimate the latent labels and the rater quality metrics. And these rater quality metrics could be in a binary case, rater sensitivity or specificity, or in a multi-class case, a rater accuracy, multi-class accuracy. And more generally, you basically are able to estimate the quantity of the probability that a rater R labels task I with a label Y, when in fact the true label is the label X. So then with this kind of probabilities, you gather the overall accuracy of the rater by taking this sum. The inference is computed with the EM algorithm. So you alternate between the M step and the E step. In the M step, you basically try to figure out the estimate for the rater quantities, such as the accuracy. And then the E step, you basically try to figure out the underlying truth, so the estimate for the ground truth. And the T here is basically an indicator variable specifying whether the target label is actually P or not. All right. So in order to implement this sort of method for estimating how good it is for figuring out the rater reliability and the ground truth, we take the data set where actually the ground truth is known. So this rare occasions where the golden data set is available. And then we pretend that we don't have these ground truth labels, and we simulate a ton of different copies of the silver data set. Even if you wouldn't have a golden data set, but only partially filled data, you can backfill it by simulating it with the underlying estimated reliability scores. So if you start with the partial data, you fill it up to get the golden data set to simulate it, a copy of it. And then you simulate the silver subsets. of this golden data set. And we will do this with a different combination of the number of tasks and the number of raters labeling each task. So this partial data, we'll investigate whether only knowing a partial picture of the data, can we back estimate the rater reliability and the ground truth. And it turns out that actually it is pretty good at figuring out what the true rater accuracy is. We basically have different combinations here. Different curves correspond to different number of raters that annotate every single task. And on the x-axis, we have different number of tasks that we give to the raters to complete. And you can look at this plot and see that even with the 10 10 labels per task, so 10 individual raters completing the same task, at 250 tasks, we already are able to have a decent recovery of the rater accuracy. On the y-axis here, I'm plotting the absolute difference between the true accuracy and the estimated accuracy of the rater. And similarly, if we look at the recovery of the underlying ground truth, we also have near perfect recovery for 10 raters per task at 250 tasks. All right. Any questions before I go on to the next section on subjective task evaluation?
Hey, Lan.
Yeah.
Yeah, can you explain why the error shrinks with the number of labels? Is there a simple explanation? Why, if you increase the number of annotations, you'll get a better score?
Sorry, on this plot for the ground truth.
Yeah.
Yeah, so the accuracy, the highest you get here is 1. So basically with more tasks, you have more overlaps between the raters, right? So you have more comparison between them. And this allows you to basically cross-check whether they agree with each other. And then you have a clearer picture of how accurate they are.
Okay, and
that wasn't here, but
so the number of annotations is the number of.
Oh, the number of annotations means the number of ratings from raters per task. So if I have a question and I have only 2, 5, 10, 15 different people answering the same question.
Okay, gotcha.
So with more people, obviously, you will be able to estimate the ground truth better. Right. So with more tasks as well, you basically also are able to see more overlap. So here the error drops. Okay. Any more questions? Okay. So I also mentioned we have inherently subjective questions that we ask the raters. And we, most of the case, we prefer to ask quantitative questions. For example, how many examples we show are incorrect, or how many are we missing? These are quantifiable things you can list. So there should be no disagreement. But sometimes we ask questions like, how is this helpful? Or how good is this feature? How trustworthy is? these are all the questions that we are interested about, that we need to ask in order to estimate how satisfied the doctors will be with the feature. But obviously, there will be different preferences, and different people have different mean score. Some of them might always say, oh, this is great. And some people might always say, oh, I don't like it. I never like anything. So how do you basically mitigate this, this kind of scenario? How do you kind of figure out how to pull all of these ratings that are available to you to get any sort of useful insight? So the usual way we handle it is to basically model the rater effect as a random effect. So here you start with a linear mixed model, and you try to use the helpfulness score, let's say, or a goodness score. Now we denote it as Rij. So Rij would be a rater J rating of, let's say, a task I in terms of how helpful, good, or trustworthy a summary of the data is, let's say. And then we will model this as a combination of other quantitative features. So additional questions that we ask about a particular example. So the axis here, the fixed effect, might be the number of correct pieces of information that are shown in the summary, or the number of missing pieces of information, or the number of redundancies, or the number of vague informations that are surfaced. You can imagine many more. So there could be other qualitative, actually, aspects, such as how fast is this feature, et cetera, et cetera. So all of these fixed effects will be used to figure out what is the highest importance aspect that influences the goodness of the feature. And we want to aggregate this across different raters. So here the Vj here is going to be a random effect to quantify the biases between different raters. The Wi will be the leftover effect for different tasks that we show, that is on top of what is not captured by the axis, so by the fixed effects. And if we are able to fit this model where the Wi's become very small, so the fitted variance is small, it means that we are already capturing most of what variability is observed in the goodness score. Okay, so you can imagine that the helpfulness score might not even be on the numerical continuous scale. Sometimes it's just categorical variables such as very good, moderately good, slightly good, or not good at all. And then these quantities might be only categorical ordered quantities. In these cases, you might want to apply some form of generalized mixed effects model with appropriate links to model the ratings that you collect. So for example, the link might be a logistic link if you have binary data that you collect. So let's say you can ask whether this data summary is good or bad. All right. So with this fitted goodness score, you can look at the coefficients we have for different axes, as I mentioned, to figure out what influences the different aspects, so how different aspects of the quality affect this heuristic subjective notion of goodness. Basically, the model will smooth out all of the different preferences and different individual variabilities between different raters in order to give you a more cleaner view of what is happening. Of course, the random effects help you remove also the rater's personal variabilities as well. So, okay, I think we are running low on time, so I'm going to go quickly over to the next project that I was involved with. So basically, the idea here was at the beginning of the pandemic, where there weren't that many models around yet. Well, we thought with the collaboration with the providers, so the hospitals, that it would be a good idea to help them figure out what is the short-term predictions that they might have for the next, let's say, 2 weeks to better plan the resources. So across all of Google, there have been many efforts to predict, but also many others like mobility reports that you might have heard about. So many different initiatives to help surfacing the information related to COVID-19. So in particular, I'm going to talk about our internal Google Health initiative to predict the hospital admission. So in basically the media, in academia, a lot of the models you see focus on either predicting deaths or predicting cases. There were very few models at the beginning that actually show you the forecast hospital admission. So working with some of the data that we have from partnered hospitals, we took this approach of multiple model fitting. Basically, we took a lot of the models from the literature that seemed to be working well and tried to incorporate and expand them to basically provide hospitalizations predictions. So the first set of models are the statistical model that is based on the Imperial College paper. And the second one is basically the curve fitting model. And the third one is the compartmental model that is based on a set of differential equations. So I was involved in translating this Imperial College renewal model and incorporating the hospital admissions into this model. Basically, the way it works is instead of using differential equations to model this renewal process with different compartments, we'll use the convolution function to model the number of infections. So you see here, the number of infection at time t and location n will depend on the previous infections at the time in the past with some sort of probability function, the PDF of a serial interval. So this is like a convolution function, and there's also an effective reproduction rate involved here in the green, and the decreasing factor of number of susceptible people. So as people are infected, there are fewer of them that remained susceptible. And then on top of that, you model the number of deaths as a function of these infections. And it's also a convolution. And you can similarly define the relation with the hospital admissions and combine all of this into a generative model and use an MCMC algorithm to fit the parameters and to generate predictions. The advantage of this method is that you not only just have the point estimate, but also have uncertainty bound that you can take to be the 95 or 50% credible intervals from the posteriors that you estimate. Okay, so one part that is interesting in this model is how you actually model the effective reproduction rate, because it's not the constant and it doesn't stay the same from the beginning until the end of the process. How you could model it is by using the mobility data or some interventions that are non-pharmaceutical interventions, such as school, business, closures, and you use all of these as covariates in the exponential function in the effective reproduction rate estimation. We also noticed before people started incorporating that reopening of the businesses and schools and relaxing different different businesses could also affect the effective reproduction rate. So we also included these new as features to model the effective reproduction rate, and this greatly helped us to model the hospital admission in certain states that either were opening too quickly or that were more stringent and enforced the face mask policy, let's say. And yeah, so here would be basically the results of some example data. And in early days of the pandemic, you have at the on the top, you have some estimate of infections together with hospital admissions, death, and also the reproduction number. All right, I think we're actually about the end of the time. So thank you. And we have a few minutes for questions. So I'm opening up for you.
Thanks so much, Lan. And if anyone has a question, they can unmute or they can type it into the chat now.
Hi, Lan. Thanks for a great talk today. So I'm really interested in the part about COVID-19 responses and preparations, because my team has also been working with Stanford Hospital in response to COVID-19. And I'm just very curious, now the vaccines are broadly spread in the States. So with is Google Health also building some models for the vaccine like injection and also the like what's going to happen after that?
Thanks. Yeah, so I didn't mention it, but we actually unfortunately discontinued this effort for collaboration with the hospital, since at the beginning it was very useful, but as the pandemic lingered, there were so many other aspects and policies that affected this forecast, and there were so many basically open source things that are available that there was less of a need for our predictions. So we don't really have the COVID-19 forecast predictions for the hospitals anymore. It was only at the beginning that basically gathering all the data and making sure that it's useful was basically what we did. And apart from this forecasting, though, there are tons of other projects, such as basically gathering the aggregated and anonymous mobility data that a lot of the researchers use to fit the predictions of COVID. And also there's, I believe, also search terms trends that is also available right now. And in terms of vaccine, which is your question, I am not aware of any modeling work that we do at Google Health. There's a lot of basically effort to make sure that the correct information is displayed on Google search about vaccination. And a lot of this effort is also with teams on Google Health that are focused on consumers. So we work with YouTube, we work with Google search to ensure that a lot of the information on the searches related to COVID are correct and there's not a lot of misinformation circulating.
Thank you.
Excellent. Well, thanks again, Lan. Really appreciate the talk. It was wonderful having you here today. And I see we're out of time, so we better end it here.
Thank you, everyone.
Thank you, Lan.
Bye, everyone.
Thank you. Thank you.
You too.